Hello and welcome to this PowerPoint. In this PowerPoint we will be talking about nasogastric intubation. So what is a nasogastric tube? It is a pliable tube that is inserted through the client's nasopharynx into the stomach. It has a hollow lumen that allows for the removal of gastric secretions and the introduction of solutions into the stomach. So the tube can be used to actually withdraw gastric secretions from the stomach or to insert feedings or solutions or medications into the stomach. So when are nasogastric tubes used? Well, there are times following major surgery or with conditions affecting the gastrointestinal tract that when normal peristalsis is temporarily altered. Because peristalsis is slowed or absent, a patient cannot eat or drink without causing abdominal distension. The temporary insertion of an NG tube into the stomach serves to decompress the stomach, keeping it empty until normal peristalsis returns. Okay, so the Levine tube is a one lumen or single lumen nasogastric tube. You can see there are several drainage holes at the distal end of the tube, and there are graduated markers along the tube, and these markers are at specific lengths, and this helps when you're inserting the tube to know, to monitor how far you've inserted the tube. This type of tube, it's single lumen, so you really never want to connect this to continuous suction, because if you connected this type of tube to continuous suction, there's a good chance the distal end of the tube would become attached to the gastric mucosa and then damage the lining of the stomach, as well as suck up some tissue back through the tube. So this type of tube is good to aspirate stomach secretions, as well as to be connected to low intermittent suction. So the Salem sump tube is a 2-lumen tube. It has a drainage lumen and then a smaller secondary tube that is open to atmosphere. And you see this little blue pigtail, that's the air vent. That's connected to the air vent. And the major advantage of this tube is that it can be connected to continuous suction, because the air vent then ensures that it doesn't provides like a little air current, so the tube itself does not get attached to the stomach lining or the gastric mucosa. And the final tube we're going to talk about is the Miller-Abbott tube. It is also a 2-lumen tube, but if you can see at the distal end, there's a rubber balloon. And what happens is once the tube, this tube is often actually goes into the intestinal tract, so it actually goes lower than the stomach. So once it is inserted into the stomach, the balloon is inflated, and then peristalsis helps that balloon actually become placed into the intestine. Okay? So one of the things we need to be cautious of is when the sump tube's main lumen is connected to suction, the air vent permits free continuous drainage of secretions. The air vent should never be clamped when connected to suction or used for irrigation. Okay, because if we clamp the air vent, then we're not getting that free flowing of air, and we can actually cause damage, because the tube and the suction can then suck up tissue. Now, it is a nursing responsibility to insert an NG tube. However, it's only done with a doctor's order. In fact, you can't even you can't even remove the tube from one nostril and insert it to another nostril without a doctor's order. So you must have a doctor's order for an NG tube insertion. The insertion is a clean technique because you're inserting the tube through the nasal passage into the back of the throat or the oropharynx, down into the esophagus, and then into the stomach. So this area is not a sterile area. The procedure is very uncomfortable, and patients experience a burning sensation as the tube passes through the sensitive nasal mucosa. And we can do a number of things to make it a little more comfortable for our patients. As well, once the tube is in place, it's still uncomfortable because you can just think of having a tube in your nose and sitting at the back of your throat, and how uncomfortable that would be. And again, we'll talk a little bit about how we can make this a little more comfortable for our patients. It's really important to note that there is a potential for contact with the patient's blood or body fluids when starting an NG. So gloves must be worn at all times, and there is a high risk of vomiting. So the operator, the nurse, should consider face and eye protection as well as a gown. Okay, because the tube is going in the back of the throat, it's going to initiate a gag reflex, and this is often associated with vomiting. So the main complications of an NG tube insertion is an aspiration. So aspiration of the contents, either of the stomach, mainly of the stomach, but it could be of any secretions that you're introducing into the back of the throat, into the trachea. Okay, and that can cause an aspiration pneumonia. And of course, there's a high chance of tissue trauma as well. And as I just said, introducing that catheter can cause vomiting and gagging, so it's really always important to have suction close by just in case anything like this happens. So as far as the nursing interventions to make things a little easier for our patients, we can help patients relax. Again, it's a difficult thing to do when you know a tube's going to be inserted in your nose, but you help them once it's inserted into their nose and the back of their throat. You can actually assist the passage of the tube by asking them to swallow, and sometimes actually giving them a glass of some water to drink as the tube is inserted helps. The use of xylocaine jelly as a lubricating jelly is often used, and not always, but it is often used in some hospitals, so we could check your policy and procedure of the hospital that you are working in. As well as sometimes you can just spray some xylocaine into the back of the person's throat, or actually into the nasal passages as well. That often can help. As I said before, it is a constant irritant to have this tube at the back of your throat and in your nose. And it's really important for us to assess the nares and the mucosa, because it's just like with nasal prongs or anything that you stick into somebody's nose. There's a great potential of some tissue damage happening around the nares. Okay. Okay, so when we insert an NG tube, we have to measure the approximate distance from the nose to the stomach, and because all your patients will be different shapes and sizes. You'll have some babies, some adults, and adults come in different sizes as well. A traditional method of measuring the length of an NG tube for insertion is from the tip of the nose to the earlobe to the xiphoid process. Okay, so that's your standard method, and that one most nurses use. There is another method which is, and it involves the marking on the tubes. And the first mark is typically 20 inches or 50 centimeters. And the tube insertion should be to the midway point between 50 centimeters and the traditional point mark. So you would use the traditional method, and then you'd use this, and then you'd check it out against this 50 centimeter mark, and then you choose the midway point between that. So that's just another way to do it. Now, the most serious complication of NG tube insertion is inadvertently putting the tube into the pulmonary, into a bronchus, and which is called pulmonary intubation. And sometimes the airway or the person's respirations will not even be affected by this, and so by observation you wouldn't even know that you've put it into the wrong airway. You've put it into the airway as opposed to the esophagus. And 1% to 2% of NG tubes placed blindly enter the airway undetected, which can lead to serious pulmonary injury. Okay, so that's why we always have to make sure after we insert an NG tube that it's in the right place, that it's not in the lung. So how do we do that? Well, there's specific agency policies, and they'll differ. So you need to find out what your agency does. But if you are going to be feeding a patient, if this is for feeding, if you're going to be putting anything into this tube, the gold standard is to have a chest x-ray to make sure that that tube is in the stomach and not anywhere else. Okay, so that is the gold standard for NG tube insertion to verify placement. Now, sometimes a X-ray is not ordered. So another way is to check the gastric secretions. So what you do, if you see on the patient on the right-hand side, the nurse is using a big 50 ml syringe to withdraw gastric secretions, and then she's verifying the pH of the secretions by the pH paper. And typically, as you probably already know, that gastric aspirates should be acidic, and typically they're less than have a pH less than 5. Okay, and respiratory secretions usually have a pH greater than 6. Okay, so we're checking to see how acidic the aspirate is that you're drawing up from the tube. And again, I've said this, one of the greatest nursing challenges is to keep a patient comfortable because the tube is a constant irritant to the gastric mucosa. And routinely looking at the nose and the nasal mucosa as well as the back of the throat, and we check that for any inflammation or excoriation, because again, it can be quite uncomfortable. So some ways that we can promote comfort in our patients is to change the tape used to anchor the tube daily or PRN as it becomes soiled. So if we keep that tube secure, it won't move around as much. And if the tapes become loose, then the tube moves around more, which potentially can cause more damage to the nose and the back of the throat and the esophagus. We need to frequently lubricate the nares. You need to provide frequent mouth care every 2 hours. And if the patient is NPO, we should allow them to rinse their mouth with cool water. If they complain of a sore throat, you can try ice packs externally to the throat. And sometimes if it's really severe, we can get the doctor to order a xylocaine lozenge or gargle, or even some gel to put at the back of the throat. Some more nursing interventions. It's our job to make sure that tube stays patent, so we need to be ensuring that if it's connected to suction, that the suction is working and there is movement through the tube. We may be ordered to irrigate that tube, and it's much like irrigating a catheter. The irrigation will help dislodge the tube if it's stuck to the stomach wall, or it gets blocked with secretions. So typically we would flush the tube with normal saline, and there are these cone tip syringes that you may have seen on your wards that would be used to do this. And we need to, sometimes we just have to reposition the patient. So if the tube is kind of lying on, or kind of stuck inside the stomach lining, then just moving the patient onto his side may help reposition that tube inside the stomach. And we may need to reassess the placement of the tube. So if we don't, for some reason, the tube is not draining properly, then we need to check to make sure that the tube is still in the stomach. So as I said, turning the client regularly helps to promote stomach emptying, but also it helps prevent blockage of the tube. And an NG tube can cause distension because the presence of the tube in the back of someone's throat causes patients to swallow large amounts of air. And that's again one of the reasons why that patient might have his tube placed to suction. But a patient with an NG tube, we really have to do a really good thorough and abdominal assessment on our patients on an ongoing basis to make sure that the abdomen is not getting too distended. Now, I think you should know the answer to this question because I said it already. You need a doctor's order always, even to change the tube from one nostril to the other. Okay, always. And again, our complications, the minor complications, it could be nosebleeds, sinusitis, which is an infection of the sinuses, and a sore throat. More significant complications include erosion of the nose where the tube is anchored, esophageal perforation, pulmonary aspiration, a collapsed lung, or intracranial placement of the tube, which is very, very rare, but that can happen. So in summary, NG tube insertion is a nursing procedure. It requires a doctor's order. It's a clean technique, but you are required to use personal protective equipment that is appropriate for the situation. It comes with a number of complications, so it's really important that you practice the skill of NG tube insertion and you are aware of the nursing interventions that are associated with the care of a patient with an NG tube. So this completes the PowerPoint on nasogastric tube insertion and patency. Please continue with the rest of the learning activities in this module.